All right, now we're getting into the dirt, the real stuff that you need to know about sleep technology. The rest is going to be on the exam probably, but not nearly as much as this stuff will be. And this stuff is actually what your job is gonna be all about. All right, pediatric sleep staging. This is for 2 to 18 years old. Like we've said before, we can use adult electrode derivation for the EEG wires, the EOG wires, and the EMG. But we want to reduce the distance between the chin EMG from 2 centimeters to 1 centimeter and reduce the distance from the eyes from 1 centimeter to half a centimeter. For pediatric sleep staging, we have W for wake, stage W for wake, stage N1 for non-REM 1, stage N2 for non-REM 2, stage N3 for non-REM 3, and stage N for non-REM, stage R for REM. Here's a special studying note. Whenever you see figures like this, draw them in your notes. Things like basic waveforms, or later on when we talked about obstructive and central apneas, draw what the effort belts and the airflow, what they would look like. If you can draw it, that means you can see it in your head. And if you have it in your head, then you know the material. Before we talk about the different pediatric waveforms you see, let's refresh on what different waveform ranges are. And one way to think about concepts like fast waves or slow waves is if you were to pretend that you had a treadmill that was fixed with rolls of paper, and when you turn the treadmill on and you put a pin down as that paper moves by and move the pin up and down. If you were to move that pin slowly up and down as the paper moves, you get slow waves, and they look kind of big because going from a low voltage to a high voltage takes more time than a smaller wave would. If you move the pin really fast when the paper moves by, you get something that looks more like alpha waves. They're closer together and a little shorter. This is exactly how old-style pen and paper sleep study machines worked. As the paper moved, the pins would deflect up or down, fast or slow, and you could tell what kind of waves they are by their amplitude, or how big they are, their duration, how much time they take up, and their morphology, what they look like. Personally, I remember as D-tab, DTAB, so that they are in order from least frequency to greatest frequency, delta, theta, alpha, beta. Delta waves are big and wide. You may sometimes have little waves riding on them, but most will have pretty nice straight lines. Delta waves are considered 0.5 to 3.99 hertz, or just under 4 hertz. And let me say, when we're scoring stuff and we're looking at stuff, we're not thinking, oh, is this 3.8 hertz? No. We look at it and we say, oh, how many waves are in this, second? And it looks like 5. That's close enough. This isn't the space shuttle, We don't have to be super accurate, but you do need to know the ranges. Theta waves are not as big, and they have less space between them. Theta waves occur between 4 and just under 8 hertz. Alpha waves are very close together and are the second fastest typical sleep waves, secondary to spindles, which were beta waves. Alpha waves are considered 8 to 13 hertz. Beta waves, like with sleep spindles, are any waves faster than 13 hertz. As the waves get faster, they get smaller. As the waves get slower, the waves get bigger. You may hear different ranges for these waveforms. For instance, you might hear 0 to 4 as delta, or 0.5 to 3.9 as delta. On the RPSGT exam, you might have a question like, what is the frequency for delta waves? And the answer might be something like 2 to 4 hertz. And that would be the answer because it's the best answer available. It's still correct because it's within the range of delta waves, although 2 isn't as low as delta waves can go. Here's a table from the scoring manual on the ages in which certain sleep characteristics appear. We've probably talked about these before, and we're going to talk about them again after this, but it's important to recognize when these things occur so you can accurately detect them on the screen. For instance, a sleep spindle at age 6 looks different than at age 1. Sleep spindles first appear sometime between 6 weeks and 3 months after birth. Slow wave activity appears somewhere between 2 to 5 months old. K complexes and hypnagogic hypersynchrony show up sometime between 3 and 6 months. Vertex sharp waves are seen between 4 and 6 months. The posterior dominant rhythm. So we call this alpha for adults because when adults close their eyes and are awake, the occipital channels show the alpha frequency. The signal is referred to as the posterior dominant rhythm, or PDR, because it occurs in the back of the brain, posterior, and it is the overwhelming waveform seen, or the dominant rhythm. In children, the PDR is not fast enough to be considered alpha, so we just call it the PDR. The PDR gets faster with age, though. Between 3 and 4 months, the frequency comes between 3.5 and 4.5 hertz. At 5 to 6 months, the frequency is 5 to 6 hertz. 3-year-olds show frequencies between 7.5 and 9.5 hertz, and 9-year-olds show a relative frequency of 9 hertz. And 15-year-olds, after another 6 years or so, show a 10 hertz PDR. Remember, these are the little things inside the EEG that we have to pick out from the background noise, which aren't, other brain processes that we don't really care about. We just want to know what's going on with their sleep. As children get older, their sleep studies look more and more like adults. The PDR will vary from patient to patient, from age to age, and it can be difficult to determine, but if you get a good signal recording of the biocalibrations, then you should be able to see PDR with their eyes closed. PDR usually shows up best just before the patient falls asleep because kids usually don't close their eyes until they're just about to have sleep onset, and they're much more relaxed than when the study was begun. There are a lot of things that children do when they're idle that adults don't. And there are a lot of things that adults and kids both do. You'll see a lot of eye blinks. The manual defines eye blinks as conjugate vertical eye movements in a frequency of 0.5 to 2 hertz present in wakefulness with eyes open or closed. Conjugate means moving together. They will look different for different patients, and you're not going to get the electrodes absolutely perfect in the right way on every patient, so that has a little bit to do with the signal. Sometimes it looks like just one eye has a little deflection and not the other. Reading eye movements are trains of conjugate eye movements consisting of a slow phase followed by a rapid phase in the opposite direction as the child reads or scans the environment. It'll look like an eye deflection that's slowly moving up and down, or moving down, and then moves up quickly, like down, 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 up, down, 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 up. Rapid eye movements are eye movements recorded in the EOG derivations consisting of conjugate, irregular, meaning there's no pattern, sharply peaked eye movements, sometimes we call these clicks, eye clicks, with an initial deflecting lasting less than 500 milliseconds. While rapid eye movements are characteristics of REM, they may also be seen in wakefulness with eyes open as individuals scan their environment. Here are some eye blinks. You can see the deflections pointing towards each other for just a very short time, and then the signal goes back down to baseline towards each other. Now, blink, blink, like that. You can also see tiny remnants of the eye blinks in the central derivations. These are eye blink artifact there. There. They kind of look like real waves, so you have to be careful with that. Here are some rapid eye movements, but you can tell the patient is awake for a few reasons. Number one, there's a ton of alpha rhythm right here, which means the patient is awake with their eyes open. You can still move your eyes while your eyes are open or while your eyes are closed. chin tone is not flat. It's pretty thick still. And the eyes are deflecting away and towards each other. Away and towards each other. And we know these aren't brain waves because the alpha is here. The eyes are deflecting towards and away from each other. Meaning conjugate movements. When the patient is awake with their eyes closed and is relaxed, the occipital derivations should show the PDR. We mentioned earlier that the posterior dominant rhythm, or PDR, increases with age. We talked about how the PDR is just what we call the rhythm seen in the O's, like alpha for adults, but it's not fast enough to be called alpha frequency, so we call it PDR. That is what we score instead of alpha for wake. Rarely does the PDR in children just show a normal wave. Typically it is intermixed with slower EEG rhythms, including posterior waves of slow waves of youth. Those are intermittent runs of bilateral, meaning both sides, but often asymmetric, meaning they don't occur at the same height. 2.5 to 4.5 hertz slow waves superimposed riding along or fused with the PDR, usually less than 120% of the PDR voltage. Block with eye opening and disappear with drowsiness and sleep. So we'll see these things. They're uncommon in children younger than 2 years of age. We see them the most between 8 and 14 years old, and they're uncommon after 21 years old. I'll show you a slide of those in just a second. Random or semi-rhythmic occipital slowing, and those are less than 100 microvolts, 2.5 to 4.5 hertz rhythmic or arrhythmic activity. Is it a regular or irregular rhythm? Lasting less than 3 seconds. It's a normal finding in EEGs children's age 1 to 15 years old, especially prominent halfway through there with 5 to 7 years. The amount of intermixed slowing, and that means, remember, if we're rolling our pen fast and then we go slower, it's going to look slower. The amount of intermixed slowing decreases and its frequency increases with increasing age. This just means the PDR begins to get slower and slower as the patient begins to be more and more drowsy. These are the posterior slow waves of youth in a 9-year-old. These are taller waves in the occipital region, the O's, and they are bilateral, meaning they occur in both hemispheres or both sides. You can see these as PDR, as a lot of kids have some kind of PDR variant that comes along with it. It almost looks like the O signal has been increased, like the amplitude or the gain has been turned up because they look so much bigger compared to the other signals. But this is just higher voltage waves coming from the back of the head. This is PDR seen in adults, and it's fast enough to be called alpha. Here's the PDR in an 11-month-old. It's about 5 to 6 hertz. You can see the vertical lines in the study. Those are seconds. So you can count the amount of waves in each one. So let's see. 1, 2, 3, 4, 5, 6. So that's about right there with 5 or 6. This is the PDR of a 12-month-old, which ranges between 6 and 7. So in just 1 month, children may increase their PDR by 1 hertz. Let's see. 1, 2, 3, 4, 5, 6. Yep, just has it. Here's an advanced PDR for pediatrics, 10-year-old PDR who is 10, which is fast enough for us to score alpha. Yep, those are good alpha waves. And you can see it kind of looks, it's got kind of an optical illusion with those straight lines against each other. that's alpha. You can look at it and just say, oh, well, that's alpha. Scoring wake is very similar to how we score wake for adults. We score wake when more than half of the epoch is either PDR, when the patient's eyes are closed, or alpha for adults, or other wakeful features like eye blinks, which are between 0.5 and 2 hertz, rapid eye movements associated with normal chin tone or higher chin tone. Remember, REM has the lowest amount of chin tone. And reading eye movements. All of those examples of PDR we just saw were good examples of wake with eyes closed. That's what it will normally look like. This theta during drowsiness looks like PDR, and it is, but we don't call PDR theta, like adults for alpha. Slow eye movements, or I like to call them slow rolling eye movements, are conjugate, moving together, reasonably regular, meaning they have a pattern, sinusoidal, meaning up and down, eye movements with an initial deflection that lasts longer than 500 milliseconds. Pay attention to those greater than or less than or greater than equal to or less than equal to, because they can just switch that thing up and that makes an answer wrong on the test, that is. Slow eye movements may be seen during eyes closed, wake, and N1. Low amplitude mixed frequency, or LAMF, are short waves, usually theta in frequency, meaning 4 to 7 hertz. Vertex sharp waves, or V waves, are sharply contoured waves lasting at least 0.5 seconds in duration, as measured by the base of the wave. They're maximal over the central region and distinguishable from the background activity. They pop out. They are most often seen during the transition from stage N1 or is seen in either stage N1 or N2 sleep. These waveforms are usually seen first between 4 and 6 months. Here's a good example of slow eye movements. They are conjugate, moving together, regular, meaning they have a pattern, which is sinusoidal, going up and down very slowly. They are rolling their eyes here. They're not as fast as rapid eye movements, they're slow. Have you ever been so tired or sleepy that your eyes crossed? Those are slow rolling eye movements. Here you can see slow rolling eye movements along with decreasing chin tone. And some small waves coming out there from the alpha. Starting to lengthen out. This is low amplitude mixed frequency, or LAMF. This is another example of LAMF. It's in a younger child. They have LAMF, but it's not as low amplitude, but that's to be expected because kids' waves are huge. There's also a nice vertex sharp wave right there. You can tell the difference between K complexes and vertex sharp waves because the V waves stay on top of the baseline. K complexes go up quickly and then down through the baseline, way down, and then travel back up. Here's a textbook example of a sharp wave. You can see it does not pass through the baseline like a K complex would. It floats on top. Here I've added the baseline to illustrate what I mean when I say the wave does not cross through the imaginary baseline. It starts, stops. It might just go down a little bit, but a K complex is going to go all the way down through the baseline. This really just stays on top of it. One other sign of N1 should naturally include sleep onset. For pediatric sleep staging, we consider the first epoch scored that isn't wake, but the first epoch scored of any kind of sleep will be when sleep onset occurs. In most subjects, sleep onset occurs with N1, but infants and children that are just months old or younger may still enter sleep via REM. Hypnagogic hypersynchrony. If we break it down, you get hypnagogic, meaning going to sleep, hyper, meaning fast, and synchrony, together in time. As we're going to sleep, we're having fast together in time waves. So these will be waves that are fast, move together as the patient falls asleep. A more proper definition would be paroxysmal bursts or runs of diffuse high-amplitude sinusoidal, up and down, 75 to 350 microvolt, 3 to 4.5 hertz activity, which begins abruptly and are usually widely distributed but are often maximum, which means it's all over the head. But they're usually seen the most over the frontal, the central, or the fronto-central scalp regions. These waveforms can occur in N1 and N2. Another wave that isn't part of the manual for scoring stage N1, but a common EEG variant that can be seen are posts, or positive occipital sharp transients of sleep. These are sharp-looking waves seen in the O's. This is a nice textbook example of sleep onset. The second signal derivation is O2, where alpha or PDR is seen in the most because it happens at the back of the brain. You can see the waves in what you might be calling beating, where they get bigger and smaller and bigger and smaller, beating. And then all of a sudden, these waves get smaller and longer, right there. When they start to separate out a little bit more and get space between the waves, and eventually becomes low amplitude mixed frequency, or LAMF. That's it. That's sleep onset. You could detect some slow rolling eye movements here as well, right there. They could be subtle. Have to watch out for those. This epic wouldn't qualify as an epic of sleep, but it's a good example of, it's not long enough, but it's a good example of attenuated PDR or attenuated alpha. This patient had huge alpha waves, and it was very clear when those waves got smaller. You can also see there's a rolling eye movement, there's a rolling eye movement, there's one. Big beating alpha right here. Beats of alpha. Right there. Look at that. There's a little bit of a wave, a little bit more alpha. But that alpha has really gone down. Look how big it is here versus how small it is here. That wave is still there. That frequency is still there. But the chin tone is relatively low. The respirations are normal. We've got slow rolling eye movements. So right in here is N1. There's a little bit, look kind of like a vertex sharp wave. Maybe. It's probably not short enough, but it's getting close. You may also see this in pediatrics, hypnagogic hypersynchrony. This is a burst of slow waves, and they are synchronous or occur together. This happens as the patient is going to sleep, hypnagogic. Here's a normal EEG variant, or an EEG rhythm that's not exactly common, but not entirely rare. If you can find the O channels, let's see, here's an O channel, O2. They deflect upwards then downwards. You see this? Remember, EEG going up means negative, going down means positive. These are positive occipital sharp transients of sleep. And we see them in non-REM. And so they're going up here. This and that's, usually that's negative, because these, if you look at the montage, it's not, to M1, to M2, to M3, to M4. They are going to different parts of the brain. So this is showing a positive correlation between whatever, I can't see, T4 and O2. Those are going to be positive. If it were O2 to M2, these would be negative. That's something just to keep in mind about. It's a silly EEG thing. 90% of patients show a PDR when their eyes are closed. For patients with a PDR, you can score N1 if the PDR is attenuated or replaced by low amplitude mixed frequency, LAMF activity, for more than half the epoch. If the patient doesn't have a detectable PDR, you can score N1 when any of the following occurs: 4 to 7 Hz state activity with background EEG slowing by 1 to 2 Hz from stage wake, slow rolling eye movements, vertex sharp waves, hypnagogic hypersynchrony, or diffuse or occipitally predominant high amplitude rhythmic 3 to 5 Hz activity. Non-REM 2 has the same characteristics and scoring rules as adults. K-complexes are well delineated, negative sharp wave immediately followed by a positive component standing out from the background EEG, with a total duration of less than or equal to 0.5 seconds. And we see them the most in the frontal derivations, the Fs. For an arousal to be associated with a K-complex, the arousal must be concurrent with the K-complex or commence no more than 1 second after termination of the K-complex. This rule is here because K-complexes frequently occur before an environmental arousal. A lot of times it's a lot of these preceptors for in sleep labs will click the intercom button and that'll arouse a patient, and right before that happens you'll see a K-complex. Sleep spindles are trains of distinct sinusoidal up and down waves with a frequency of 11 to 16 Hz, most commonly 12 to 14. They have a duration of less than or equal to 0.5 seconds. Usually we see them in the central derivations, or the Cs. Here's a decent K-complex. Negative, going up. Sharp. Negative, or positive, going down. That is a K-complex. Backwards check mark almost. The difference is the downwards deflection going through and past the baseline, because I think they look a lot like vertex sharp waves, right? There's my baseline. It goes up through and down through. Almost looks like the exact same amplitude on each side. Here's a sleep spindle. It's a very tightly wrapped up coil. These look a little similar to alpha waves because they are fast like alpha waves, but these are really tight. There's almost no daylight in between those waves. Alpha, you're going to have a little bit more. I'd almost say that alpha, you'll have the line and then a space where a line could be exactly the same size as a line, and then another line. Here's a textbook example of N2. It's chock full of sleep spindles. Here's a sleep spindle. Here's sleep spindle. Here's sleep spindle. And we've got a K-complex here. Normal chin tone. It's not too high. It's not going crazy. And lamp. Low amplitude, mixed frequency. Here's what pediatric N2 would look like. Check out how long these spindles are. That's a long spindle. And here's one right here. That's a long sleep spindle. Also near the end of the record, there's K-complex right there. But this EEG, remember, I'm throwing up some funny EEG things. This is not a typical sleep montage. It's for looking at seizures and stuff. So it's looking from F3 to C3. If this was F3 to M2, this K-complex would be backwards. It would be up and then down. So that's why it looks like that. The electrodes are linked together. So the big K-complex appears to be upside down. And it is on that side, but we're looking at it through a different camera view when we link it to regular mastoids. But because it's linked to F3 to C3, it's showing the path of the signal. Stage non-REM 3 is scored just like adults are scored. But remember that kids are growing more than adults, and so they have a lot more slow wave sleep, and they have greater amplitude instead of the required 75 microvolts. It's common to see 100 to 400 microvolt amplitude, and that's huge. It's always 0.5 to 2 hertz maximal over the frontal region. Used to, and you've probably noticed a lot of these old EEG slides, there were only a C and an O. Fs weren't added until later to qualify slow waves. The first slow waves can come around 2 months of age, but more often between 3 and 4 months. This is a native EEG signal. It hasn't been changed at all. A lot of these textbook things have they've taken some filters to take out some of that faster frequency, but you can still see we've got these are kind of small margins. Like this is where the waves are supposed to be, and they're just going way outside. If you wanted to stop that, you could add pin blocking, which would make the highest or lowest point just kind of a square. But that makes it look awful, and you can't really read the waves because you can't really tell how big they are. And of course, REM is scored the same as adults. For REM, you want low amplitude mixed frequency, LAMP, in the EEG, but the frequency value will change with age. The background LAMP frequency for 7 weeks old is about 3 Hz. 5 months old shows 4 to 5 Hz, and bursts of sawtooth waves. The background increases to 4 to 6 Hz at 9 months old. When patients reach ages 1 to 5, you expect to see more prolonged runs or bursts of notched 5 to 7 Hz theta activity. At 5 to 10 years of age, this LAMP will be very close to that of adults. When children are just weeks or months old, it can be difficult to find the eye movements because the musculature is just not as developed to show up on an EOG. So sometimes you have to rely on the respirations being irregular or a low chin tone and LAMP for sawtooth waves in the EEG. That's why you have to have all this stuff, because it can help you figure out just one thing. Here's a nice diagram of sawtooth waves. Usually they have a notch in them somewhere. Looks like maybe right there, and sometimes at the top. Here's a great sample I ran many years ago with some outstanding sawtooth waves, and I've enlarged the section to show you. These are the sawtooth waves. Those are brilliant. And they are notched. Here's a nice example of low amplitude mixed frequency all throughout the EEG, and this is an adult for reference. LAMP. Beautiful LAMP. Beautiful low chin tone. Beautiful eye movements. Check out this. These look like waves, but they're occurring with the eye movements. The patient is totally still. So these are actually coming from the eye muscles. That's what is being picked up, especially in the Fs, because those are closer to the eyes. So this really would just be as flat as the O's would be, but because they're closer to the eyes, it picks up the electrical current that the eyes generate when they move. This is a pediatric sample of REM, and the LAMP is much higher amplitude than the previous slide. At the same time, you can have eye clicks with a steady low chin tone. Those look like sawtooth waves right there. Here's a sample of lower LAMP. There's some sawtooth waves, and maybe an eye click there in the C region. You see where the EOG should, right here, where it should still go out, but it's squared off. That's called pin blocking. Back in the day when we had pins on paper, the pins couldn't go past a certain boundary, so they would just go as far as they could and hold it there. And you can see this in digital recordings also on the computer, but you can turn that off, and the waves will just travel further. Here's a hypnogram of a 5-month-old, and it just shows you the cycles through time. There are so many cycles, and part of the reason is because their cycles are shorter than the typical 90 minutes that older children show. Infants and babies also have, they sleep half active, half quiet. But when we talk about infants more, we'll go over infant sleep staging a little bit more. Okay, this is the first one. Really try and make flashcards with this stuff. Characteristics of pediatric N1, N2, N3, and REM and wake and all that. It'll be important. If you can memorize these things now, it's going to make total sense later, and especially for the exam. All right, we'll see you next time.